Professor Dr. Heba Ghazy for the Pediatric ECG workshop. She is a senior specialist of pediatrics and pediatric cardiology in KidsHeart Medical Center in Dubai, UAE, and she's a lecturer of pediatrics in Ain Shams University, Egypt. Welcome, Dr. Heba. Please clap your hands for Dr. Heba.
Thank you, Dr. Ayman. Thank you for all the attendees who stays till now. I know you are all tired after 3 days of lectures, but we will try to make it practical and we will try to make it short, okay? So I would like to thank Dr. Muhammad Hamdan. He's not with us now, but this workshop was his initial presentations and we just did some modifications for it. Okay, so we'll have a short introduction. Yeah, the first thing is children are not small adults. Why I'm saying this? Because each day in the hospital, I'm receiving ECGs to comment about, and the doctors from the ER will call me while he is so afraid because it's saying that this ECG is showing anterior wall ischemia. Just because they didn't put the patient age, so the machine read it as an adult ECG, so what is normal for the pediatric ECG is not normal for the adult ECG. So this is the first message of this. Please ask the nurse to put the patient age and data on the ECG machine. This will save us all a lot of hassle, okay? So this is a simple diagram showing us the electrical system of the heart. We all know that the heart cells is different from the other cells so that it has automaticity and it's capable of conduction. Any cell in the heart can produce automatic signals, but the SA node is the pacemaker because it has the high rate, okay? The SA node is present on the surface of on the top roof of the right atrium. Then we have the internodal pathway that connect to the AV node, and we have the conducting system between the right atrium and the left atrium. Then the signal will move first from the SA node to both atria to be activated first, giving us this B wave. So the signal will move from the SA node. Why the SA node? Any cell in the heart can produce electricity, but because the SA node has the highest rate, it will be the controller, okay? So signals will be transmitted through the atria, giving us the first signal, that is the P wave. The P wave is for the atrial activity. Then the signal will reach here. This is the AV node, okay? It's in the junction between the atrium and the ventricle, okay? The signal will be here, will be delayed in the atrioventricle for a few milliseconds. Then we will start the ventricular activation. The signal will move here, and we will have the conduction system, the left ventricle. The bundles that go into the left ventricle will divide into the anterior fascicle and posterior fascicle, and then we have the right bundle branch. When the ventricle is activated, we will have this QRS complex, okay? Because the atria was activated before, now the atria will be deactivated, or what we called it will be repolarized. Repolarization of the atria will happen in the same time that the QRS is happening. So we don't have a separate signal for the atrial repolarization. We don't see it because it happened on the same time. Okay, then the heart will start to repolarize, the ventricle will start to repolarize, and this is when we will have the T waves. This is again what we said. This is what we call the signals. This is the P wave. It starts here, the activity of the atria start here, and then this is the time till we reach the AV node. All this is called the PR interval. Then we have the QRS complex, which denotes the ventricular depolarization. Then we have the ST segment, which is very important in ischemia, pericarditis, myocarditis. Then we have all this is about the ventricular repolarization. Okay, so what happened, like small infant and not like adolescent and not like adults? There is continuous change in our body, and this change is reflected into our heart electricity. While we are in utero, the dominant side of the heart is the right side. Then this shift to the adult life where the left side is the prominent side. This is seen in the EKG. So when we have an infant, the most prominent signal will be the signals of the right ventricle. Then we move to left ventricle dominance. Also, while we are in infant, we have a short PR, and this PR will start to be longer by time. All the signals will become will be short. Like the PR will start we will accept something like 90 milliseconds when we are born. Then it will progress to 140 or something. The corrected QT interval is the opposite. Usually, it decreases with age. This is the most important thing, that is the normal values. As we have we have many normal reference value in the labs and in everything. In the ECG also we have some normal values. Here is a small gift from us. This is one for you. Dr. Omar will help. Shukran. Okay. So as we see here, the PR will increase with age. The QRS complex will increase also with age. Okay, so basically, what is the ECG? What is anyone can give us the definition of the EKG? What is the EKG? Yeah, so it's an electrical presentation of the electrical activity of the heart. So why do we have 12 leads? Do we have 12 different electricities in the heart? Bravo, it's different views of the same thing. It's as if someone is standing and we are taking different photos from him. So in each photo we will be focusing on a specific part of the heart. This is what will give the difference in each leads, okay? We have 12 fundamental leads and 2 extra leads, the augmented leads. These are the limb leads. When we do the ECG, we use the right arm, left arm, and left leg. The right leg, we don't use it. We just put a sticker there, that's what we call the ground, okay? And then we have lead 1, lead 2, lead 3. When we measure in each lead, we will measure the difference. Like what is the machine reading electricity from one point, and we'll compare it to the other point. So it's the difference in the electrical potential between the 2 points. So we will have what we call a vector. A vector is a magnitude of power with a direction, okay? Because the electricity, our SA node on the top right, and the electricity is moving to the top left. So electricity, like in lead 1, we are measuring the difference between the right arm and the left arm. So we are moving with the direction of the current moving from the SA node and going this. So the main forces will be positive. But here, in the lead 2, we are just going just parallel to the exact line of the electricity that is moving in our heart. This is why in the lead 2, we will be getting the highest QRS complex, because we are exactly moving in the way that the electricity is moving inside our body, okay? In the AV node, in the AVF, we are measuring the electricity that is going toward the foot, so also we are going to get mostly positive waves. Here we are going on the other way, so mostly the negative waves is higher, and here we are moving completely away, so all the lead is negative, okay? So these are the 14 leads, 12 are essential, and these are what we call the right ventricle augmented leads. Usually we don't use them except in specific cases that is not our topic. According to the lead positions, we are seeing here that some leads are focusing mainly on the right ventricle, some others on the left ventricle, and the other will be giving us the size of the septum and the condition in the septum. So, V1 and AVR will be speaking about the right leads. Left ventricle will mainly see the activity in lead 1. In lead 1, as we said, because the electricity is moving in this way, and in VF, And in the inferior leads, this will be focusing more on the septum in lead 2, lead 3, and AVF. Okay, so usually the first thing when you ask the nurse to have an ECG, then the nurse will give you the paper. First thing, you have to know that the electrical interpretation that is there, usually we will not rely on it, okay? Because there are many problems. There are things that are correct. The machine, yeah, shukran. There are things that we know that the machine is good in calculating it, like the heart rate, the PR interval, and the axis, whether it's right axis or left axis. There are things, we don't rely on the machine on detection of arrhythmia, and most important, on detection of the corrected QT. We have to do it manually. We have to calculate it manually, especially the corrected QT. Okay, now we will, like after this theoretical part, we will move to how I'm going to read the ECG when I'm giving it in the clinic. First, I will look to the machine if they wrote the age of the patient or not. And then I will look at what we call the calibration, is that I'm teaching the machine, I'm selecting on the machine how much I want the height of the complex to be, okay? And then the speed, we will speak about it then we will go to something that we will see in the limb lead, that is lead 1, 3, AVF, AVR, AVL. And then we will look for the chest leads, what we are supposed to look for. We will go through this one by one. Age is the most important because, as we said, as you have in the chart, everything has to be compared for the age of the patient. Then we have the standard paper speed. Usually the paper will, the machine will move the paper, so we have 25 millimeter per second. So this means each small box will be taking 0.04 part of a second, and the large box will be taking 0.2 of the second. This is important when we calculate the heart rate. And then usually in the calibration, we use the full standard calibration, where 1 millivolt equal 10 millimeters. So 1 millivolt will be 2 big squares. So here, full standard calibration, you see here this is the calibration signal that we use the arrow. This means 1 millimeter, 1 millivolt equal 10 millimeter. And then we have the speed. So you should look down. They usually write it down, okay? Why do we have this full calibration and half calibration? Because ventricle who have like severe cardiomyopathy or ventricular dilatation, sometimes we need to do half calibration because the ventricles are very large. So you will have QRS complexes very high. So the images will be conflicting from each lead with the other leads. So in these patients, we use half calibration. But the standard practice is to use the full calibration. And you have to check in each ECG that you find that the calibration is full. For the speed also, this is important to check that you are having the speed so you are calculating the correct heart rate. In ECG, this ECG here, we have half calibration. You see, this square, it's equal 1 big square also, not 2 big squares. So this is usually, as we said, in patients with dilated cardiomyopathy or complex congenital heart with single ventricle with huge conduction velocities. Now we will start to look in the limb leads. In the limb leads, we focus on 4 things. And this is the way I want you to read any ECG. This is a very simple way and simple and to the point way to read the ECG. You just have to look for these points and you will be done. First is this patient, what is his heart rate? How do we calculate the heart rate? There is many ways, but usually we use the box method. So this is the QR complexes. We will imagine that these are the complexes. We count. If we have one complex in one big square, we divide the number of, we use this formula, 300 plus the number of large boxes. So let's say that I have one complex here and the other complex is here, okay? So I have two big squares between the two R waves. So I will divide 300, divide by 2, it will be 150. If I have this R and the second R is here, so I have 3 big boxes, then I will divide 300 by 3, so it will be 100. There is many ways, but this is the most traditional way that we use. Then we go to the axis. We will speak about, I will not speak about the B wave axis, I will speak about the QRS axis. There's many ways to determine the QRS axis. The simple and easy way to look for lead 1 and to look for AVF. As we said previously, lead 1 is going from the right hand to the left hand. So we are suggesting that usually it should be positive. And lead AVF, we are measuring the activity going toward the left foot. So usually we are expecting it to be positive. We will have this circle here, 0 is here, and we go positive here and negative upward. Okay, so if it's positive in in lead 1, this is this line represents lead 1. Okay, so I will see where is my signal and I will start to count. And this represents lead 1 and this represents AVF. Okay, so like in the first case, lead 1 is positive, so it's here, and lead AVF is positive, so it's down, so the axis in this square. Okay, in the second one, it's positive in lead 1 and it's negative in the EVF. So it's up. So this patient have left axis, okay? Here it's negative in lead 1 and positive in AVF, so this patient has right axis. And this is negative here, and this is what we call superior axis or abnormal axis, and this is never normal, and it's not ever accepted. Also, this axis differs according to the age. Usually when we are born, we have some right axis deviation. Yeah, this is the normal in the pediatrics. So it's either in this square or little bit right axis. And then when we get older, we start to move from the right axis deviation, and usually we are between the 0 and the 90. Up is left axis deviation. Up is what we call extreme axis or superior axis, and this is never normal. The left axis deviation, especially the superior axis, is never normal. Okay? So here, let's look to this example. Where do you see the lead 1 is positive? Which lead we will go? Lead EVF. Is it positive or negative? It's positive. No, positive. What do you think? Positive or negative? Negative. Yeah. This and this is a little bit shorter, so it's negative. So this patient have left axis deviation, and this is what we said is never normal, never accepted. This can be seen in common AV canal in tricuspid atresia. Okay, and then, so we answer the questions of the rate. We will use it by the box method. Then we have the axis of the QRS and the B wave. Then we will look if this patient is in sinus wave or in sinus rhythm, or he does have arrhythmia. This is very simple. We will look to the B wave. To have normal axis, we have to have four things that if I see them, I will say my patient is in a sinus rhythm, he's not in arrhythmia. First thing, that the B wave should be positive in lead 1 and AVF, and it should be negative in AVR. So this is the first thing. It's positive in lead 1, in 1 and 2, and AVF, and it's negative in AVR. And then we should have 1B for each QRS complex. So I have 1B, 1 QRS complex. I don't have drop complexes between them. And then the BR interval should be fixed. PR interval is fixed. Like it's always, if I calculate it manually, I will find the same PR interval, and the B wave morphology is fixed on the same, on all the leads. It's not positive in some, like if I followed lead 2, in the down paper, you will have lead 2, complete lead 2. It should be all the way similar in the same lead. Okay, so here, look. Negative in EVR. So I can say that my patient is sinus, and this is the long strip lead 2. I should see that the B wave is similar all through. No shape of the B wave. And the PR interval is fixed. Okay, so let's look to this patient. What does the patient have? We have positive P wave in lead 1, positive P wave in lead 2. And then in the AVF, in the AVR, it's negative, okay? In the AVR, it's negative. So my patient is not in sinus rhythm. Okay, and this is something that is benign, but usually we are like, people become confused with his. In this patient, we have the P wave, it's positive here in lead 1 and lead 2, and it's negative in the AVR, but the B wave keeps changing its position, keeps changing its shape. Like we have different shape of the B wave. Like here we can see the B wave is negative, then it turned out to be positive. Then if we look to different part of the strips, we have different shape. So this is what we call wandering pacemaker. This patient, sinus node might not be very active, so it's sometimes would prefer to sleep. Two other cells next to it will perform its function, so they will give us a different P wave axis. But this condition is very benign. We diagnose it when we have 3 different shapes of the B wave, but the patient is still on sinus rhythm. His B wave is mostly positive in lead 1 and lead 2, and negative in AVR, and the PR interval is also fixed. Okay, so we look to the PR, to the B wave. Now, what is the shape of the B wave? What should it look? The normal B wave usually doesn't exceed 2.5 small box. If this B wave become taller, I would expect that my patient has dilated right atrium. If the B wave is longer, this patient has left atrium enlargement. So let's look to this B wave in the second line, in lead 2. What would you comment about it? The B wave is more than 2 boxes in length, okay? So this B wave is not normal, because we said that the normal is around 2 to 2.5 small boxes. Here we have very prominent high B waves. So this means that this patient has right atrial enlargement. Now we will look to the Q waves. Q waves is one of the main differences between the pediatric and the adult ECGs, because in the pediatrics, we can have normal Q waves, especially in the V leads like V3, V4, V5, because they represent the septum. In adults, they are very afraid because it represents mostly ischemia. Okay, so Q waves are not infarction. They represent the activity of the ventricular septum. So we should look for lead 3 value for age. Most important that I will say the chart, the values for age. In anything you will see in the ECG, you should keep this in your pocket, and once you get a value, you look and you compare this with the value for age. Okay, so it's normal to have it in the inferior lead and in the middle leads that V4, V3, and in the AVR. It can be up to 1 box in width, so it's a narrow wave, and it can be up to 5 boxes height. It's abnormal when it's very deep, deeper than what we said, and if it's present in lead 1, usually we don't have it in lead 1 and in AVL. It's very deep. Usually it represents septal hypertrophy and left ventricular hypertrophy. Okay, so what do you think here? How many small boxes is it? Yeah, it's about 7. So it's more than 5. So this patient has ventricular hypertrophy or septal hypertrophy. Okay, so what did you say about the limb leads? What are the most important? Who can tell me? What are the points we set? What are we going to look for? In the limb leads, yeah, what are we going to look for? Huh? First we will look for the rate, then we will look for rhythm, axis. No, we will not look for the ST segment, you forgot. We will look for the rate, we will look for the rhythm, we will look for the axis, we will look for the B wave, we will look for the Q wave. So we have 5 things to look for in the limb leads. Lead 1, 2, 3, and AVR, AVL, AVF. Rate, rhythm, P wave, Q wave, and axis. Okay? So then we will move to the chest lead. As we said, there are 8 chest leads, but usually we are using 6 only. What we are going to look for? We looked for the B waves in the limb leads. Then we are going to look for the, P and Q. Here we are going to look for the T wave, for the more details in the QRS complex. First, we look for the T waves, because this T wave is a big problem between us and the adults. Yeah, T wave, in the first week of life, they are positive in V1 and V6. Then starting from 1 week till adolescent, they are normal to be negative in V1. In adults, this means ischemia. In infant or in children up to adolescent, it's normal to be inverted. If we find it positive in V1, this means that the right ventricle is hypertrophied. And then after adolescent, we are turning to adult, it should be positive. So we should notice that T wave should be always positive in V6. It's never negative in V6, or this means we have a problem. Then it's mostly in what we'll see in the pediatric practice, you should see that the T wave is negative in V1. Okay, so this patient is 1 day. Where should we see the T wave? In V1, positive. Because he's 1 day. We said in the first week, it will be positive in V1 and in VF. So this is normal. In 3 months, where's the P wave? Negative in V1 and positive in V6. And then in 6 years, also negative in V1 and positive in V6. And then in 15 years, we are now turning to be adult, so it will be positive in both V1 and in V6. Okay, so in this patient, we have more of a flat or positive T wave in V1, and this means that the right ventricle is hypertrophied, because as we said that usually V1 and V2 represent the right ventricle activity, 3 represent the septum, and 3 and 4 represent the septum, and mostly lead 6 will be looking for the left ventricle. Okay. So this patient, where is his T wave? Yeah, it's positive. Yeah, positive in V1 and negative in V6. Yeah, thank you. We don't know how old is the patient, but if he is pediatric, he has it negative in V6. So this means there is something wrong in this patient, okay? Okay, then the RSR dash. Usually we look for this pattern in V1 or V2, but mostly in V1, okay? When we have this, usually we are used to having Q, then R, then S. This is different shape. Usually we call the first negative deflection is Q, first positive deflection is R, and the second negative deflection is S. So this patient, does he has a first negative? No, he has R, and he has, this is the first negative deflection, so it's S. Then we have a second new positive deflection that should not be there. So this is what we call it R dash. This can be normal, or it can be in right ventricular hypertrophy, or it can be in right bundle branch block. How would I know the difference between the three of this? I will have to look for two things. I will have to look for the duration and for the height. So, if I have this shape, okay, I should ask myself, we said that the QRS in the pediatric, usually its timing is 0.08 seconds, okay? So when I see this shape, I will look, are we in the normal range? Are we in the normal range? If we are in the normal range, I will look, what is the height of the R dash? If the R dash is less than 10 millimeter, this means I'm normal. If the R dash is very tall, it's more than 2 big squares, this means right ventricular hypertrophy. So the first thing, I will look for the time. When I see this RS R dash, I will look for the time. Are we in the normal QRS duration, or is my QRS duration borderline, or is my QRS duration prolonged? If we are in the normal duration, I will look for the height of the R dash. If it's normal, less than 10 millimeter, 10 millimeter, it's normal. If it's more than 2 big square, this means right ventricular hypertrophy. If the QRS is borderline, it's between 0.08 and 0.09, this is what we mean incomplete right bundle branch block. So you will have a wider complex, little bit wider complex, but this we call incomplete right bundle branch block, or sometimes they call it non-specific interventricular delay. You'll find it in other places like this. And if the QRS complex is far below the normal, far higher than the normal, this will mean right bundle branch block, okay? So we'll look for the timing, and after the timing, we will look for the height. Okay, so this example, we have, what do we have here? We have R, then we have S, then we have R dash. The and the QRS duration, is it normal or it's abnormal? It's normal. So we will look now, it's normal, so I will look for the height of the R dash. Where's the R dash? It's very short, okay? So this means what is my patient? Normal, because the duration is normal and the height of the R dash is less than 10 millimeters. Okay, so for this patient, I will look here. The duration is normal or abnormal? Duration is normal, so I will look for the height of the R and R dash. What do you think of the R dash here? It's very high, it's more than 3 squares, okay? So my patient will be where on this diagram? So the duration is normal, but the height of the R dash is more than 2 big squares, so my patient has right ventricular hypertrophy. And here, the duration is very, very long duration. Usually we see this after surgeries, surgery that involving cutting the conduction system of the heart. Like you will see this in most patients who has ventricular septal defect repair or fallow repair or anything. Okay, so we spoke about the T wave, we spoke about the complex, and now we will speak about the R wave and S wave. This will help us to see if the patient has ventricular hypertrophy. Okay. So this patient has 8 years. Let's look to V1 and let's look to V6. Usually here, the R wave is short. Then as we move from the V1 to the V6, the R wave will get longer and the S wave will get ischemia. This is not very frequent in the pediatric practice. Okay, usually in us, it will keep us to look more to pericarditis or pericardial effusion or these issues. Rarely we see cases of ischemia. So we will consider ST segment depression or elevation. It's above, usually not 1 millimeter, usually if it's more than 2 millimeter from the normal line. Then we will go to the big problem, which is the corrected QT. As we said before, the timing from the start of the timing from the end of the Q to the end of the T, from the end of the Q to the end of the T, this is what we call the QT interval. This interval represents the area that the heart is relaxing again. It's going to repolarization. If we have a problem of the QT, the QT is prolonged, usually we have a very serious disease that is called prolonged QT interval. That is a cause, it can be a cause of sudden death, it can be a cause of syncope, and usually it has some genetic and familial problems, so it's very important. The most important thing that we don't rely on the machine to calculate it, so we should rely on it. We know that it's a little bit long in neonate, then started to get shorter, and usually it's longer in females than males. How to calculate the QT interval? We will look here. Sorry, I'm a little bit short. We will count the beginning of the Q till the end of the T. So you should find a nice Q and a nice T. Usually we do it in lead 2 and in V5. And usually we will like to find an area where the heart rate looks regular, like the baby is not moving, not crying. Then we will measure the QT. And the area that we will measure on the strip, we will multiply it by, like I will say now, let's say I have like 12 small squares, okay? I want to calculate these squares, I want to divert them into timing, into seconds. So as we said before, each small square represent 0.04 part of the second. So I will multiply like the number I got by 0.04. And then I will go to the RR wave. So like if I'm going to use this, I will start to measure from here till the end of the T. Then I will go to the preceding RR. I will count the small squares. Then I will multiply this small squares also by 0.04. Then we will do Bazet formula. Why do we have the Bazet formula? The Bazet formula it relates the QT interval to the patient heart rate. We use it in pediatric because we have fast heart rates. So we use the Bazet formula. As we said, this is the Bazet formula. It's here. I will measure the QT from the start of the Q to the end of the T. I multiply it by 0.04. Then I will go to the preceding RR interval, and I will take the square root, and then I will have the corrected QT interval. Here also you will find the normal. Yeah. Okay. You should refer also to the normal for the age, for the corrected QT interval, but always remember that corrected QT interval, we don't like to accept anything above 470 milliseconds. Okay, so this summarizes all what we have said till now. So we will start the practice. So in the limb leads, first I will look to the rate, looking for the box method. I will look for the axis. I will look for my lead 1 and lead AVF. And I will look to see where is my axis. I will look if my patient is in normal sinus rhythm. Who remember how I know my patient is in normal sinus rhythm, Doctora? Normal sinus rhythm, how would I know it? Doctora will answer, Doctor? ها هي قالت خلاص. Regular BR interval. Uniform shape of the B wave. Yeah, upward in A2 and AVF and negative in AVR. Okay. Then we will look to the P wave. We said if the P wave is long, this mean. And if the P wave is prolonged, this mean. Left atrial, okay, bravo. And then we look for the Q waves, and as we said, Q waves are different. It doesn't mean ischemia. Mostly we will look for it. If it's more than 5 small squares, it will mean that we have, bravo, hypertrophy. Then we will go to the chest leads. As you said, the most important thing is to remember that the T waves, it should be always positive in V6, but it can be, usually you will see it negative in V1, except in the first week of life and after adolescence. We said how to know that if the RSR dash is normal or not normal. How would we know? We will look for what? First, we will start by the duration. If it's less than 0.08, I will look for the height of the R. If the R dash is longer than 10 millimeter, this means that is right ventricular hypertrophy. If it's less, this means it's normal. Then if the complex duration is borderline, this means that this is incomplete right bundle branch, and this is normal variant in many of us. And if the complex is wide or more than 0.09, this means that we have right bundle branch block, and this is usually, we see it either when the heart is dilated or post-operatively. And then we said that we will look for the pattern of progression. We said that the R wave should be small in V1, then it progressed to be long in V6. Then we said that we will look for the S segment, and it should not be more than 2 millimeter above or below the line. And then we said that we must calculate the corrected QT manually, because the machine is not accurate in correcting it. So this is the summary. You will find it here on the back of your cards. So kindly, the most important of the lecture is to get the card and take it home and not to waste it. Keep it in your work bag or keep it in your desk on the office. Okay, so it has all what we said. It exactly goes as we said. You will find all the calculation and how to say that there is left ventricular hypertrophy or right ventricular hypertrophy or anything. Okay, so let's start. I don't know, we can come closer. So I don't use the mic. We can come closer. We will start to revise the cases. And you can come closer. Bring the chairs closer. عشان نصحى بقى خلاص. يلا now خلاص كل واحد ايه take off the blanket and start to awake. يلا move forward. Remove the blanket and start to get awake. Okay? يلا. Okay. So let's look. يلا who would like to present to يلا. We will start by Dr. Omar. يلا. أول حاجة we will look for what? Limb leads. I will look for the limb leads. First, tell me what is. Bravo, Dr. Ayman. Speed and calibration. خلاص? And then, do we have the patient age? Yeah, okay. So, we are having 2 years old. And we have the calibration and the speed. Okay. So, starting by the limb leads. Rate. Bravo. Who will tell me the rate? 300 divided by around 2.8 or something, okay? So it will be something close to 100, okay? Yeah, so this is the rate, the rhythm. Is my patient is in sinus rhythm or not sinus rhythm? It's positive in lead 1, positive in lead 2, negative in EVR, positive in EVF. Does the B wave has the same shape? Yeah, does it look the same? Is the PR regular? Yeah, okay, so this patient is in sinus. Then we have the axis, the QRS axis. This patient in positive in lead 1 and in positive in AVF. So normal axis between 0 and 90. Then what do we have on the again, rate, rhythm, axis, P waves, bravo. We will look for the P waves. P waves, is it more than 2? I think it's fine. In lead 1, it's fine. It's not long, it's not prolonged. Okay, there was one thing else in the limb leads. Q waves. Q waves, Do we have very deep Q waves? Okay, so it's normal. Okay, now we will go to the chest leads. What we are going to look for in the chest leads? Yeah. QRS duration, is it more than 2 squares? 2 small squares? No. Yeah, no. And the RS, the R dash, is it taller than 10 millimeter? No, so this is normal. Then what do we have? The ST segment, The ST segment, or is it on the same level of the of the BR segment or a little bit elevated but less than 2 millimeter? Yeah. Yeah. In the chest leads, is it on the same of the PR interval? Is it isoelectric? Not significantly elevated. Okay. Okay, so this patient is normal. Okay, rate is 115, axis is normal, normal sinus rhythm, P wave normal, Q waves not found in lead 1. T wave is normal in V1 and V6, RS normal, RS duration, RS normal, ST segment normal, collected Q2 normal. Now we have this second case. Who will start? يلا هنضحي بمين? Who will start? Dr. Priyanka, you will start. We will start with the limb leads. First thing is you have the card? Yeah. Okay. We start by the calibration, and we will start to say if we have the patient, you can give it to anyone who doesn't have it. Do you have a normal calibration? Yeah, it's here, 25 millimeter per second and 10 millimeter for 1 millivolt. So this is normal. And we have the patient age, so we'll be able to start. Okay? Yeah. We will start by the limb leads. First thing is the rate. Yeah. Yeah, around 300 divided by 2.5. Yeah, something like this, okay? And then after the rate axis, okay, so we will look for lead 1. Is it positive? What do you think? Yeah, it's in the middle. It's okay. And then we will look for AVF. Is it positive in AVF? It's negative. So this patient axis is where? So this patient is like it's in equivocal in lead 1. So we'll consider it positive, and in lead AVF, it's negative. So this patient axis is above, so posterior axis. Okay, is this patient in sinus rhythm? Where is the P waves? Yeah, they are positive in lead 1 and lead 2, negative in AVR. They have the same morphology if you look to the same lead, and the PR interval is regular. Okay, so this patient is in sinus rhythm. Then we will look for Q. We will look for Q in lead 3, huh? Huh. It's deep, yeah? Yeah. Okay. It's deep, okay? Okay, now let's go to the chest lead. Yalla. T waves are positive or negative or what? Negative in V1 and positive in V6, huh? This is normal for age, okay? Then we will go for what? R, the R waves. R, the R waves. What do we have here? We have R, S, R dash, okay? R, S, R dash. And the QRS complex is narrow, but the R dash is very long, okay? So this is abnormal. And then we will look for the ST segment. Is it fine? It's fine. It's, yeah, it's not below the PR line. And then, can anyone calculate the QT? We start from here till here. You can calculate using the mobiles. Use your mobiles or have calculated. Anyone can give us the corrected QT. We will start from here till here. We will count how many small squares. Then we will count this small square. We will multiply it by 0.04. Then we will go to the RR interval before it. We will see how many small squares we have. And we will multiply by 0.04. Then we will get the square roots. Do it on your mobiles and tell me what do you find. Anyone finish the calculation? No, we have 20 patients. We have to go. لا يعني we have to be faster. So the small squares from here to here. From here to here, small square, and we will multiply it by 0.04. Then 400, Dr. Ayman. Okay. Okay. So this patient, he has normal sinus rhythm. He has right ventricular hypertrophy. You see when we said that the R dash is very long and his corrected QT is normal, it's 400 something, okay? So right ventricular hypertrophy can be seen in any congenital heart that will lead to the right atrium to be in, to the right ventricle to be in more control, like in the TOF, ASDs or pulmonary stenosis or pulmonary hypertension. Okay. Okay, so this ECG, who's going to work with us? دكتور وقفي يلا وقفي عشان نصحى calibration برافو yeah okay rate okay then we go to the axis okay so it's positive in 1 and negative in positive in AVF so right the axis is correct يعني QRS complex QRS axis is normal then we go to the rhythm so the P is positive in V1 and lead 2 and and AVF and it's negative in AVR so this is normal sinus rhythm then I see the B waves and so the B waves are a little bit يعني okay okay QRS then we look for the Q in lead 3 there is no Q okay then we go to the chest 3 bravo so good VR progression and the chest 3 okay the R start to be short then it gets longer okay then we go to the ST segment T wave yeah T wave so T wave in V1 positive in V6 okay yeah no do we have RS dash RSR dash no we don't have okay and we don't have ST segment elevation okay It's normal. Corrected QT is normal. Yeah. Mm. It's prolonged. The normal PR interval in children is up to 0.14. So this is prolonged. What do we call the prolonged PR? First degree heart block, and this slide is to just remind you that first degree heart block is a benign condition and usually it's not associated with any significant arrhythmia, and many of us can have it. So this is first degree AV block, normal sinus rhythm or first degree AV block, and this is normal otherwise, and usually this is not significant finding. Many of us can have it. Okay, let's look to case 4. 3 years old. We don't have the calibration, but we will imagine that it's normal. Yeah, the calibration is missing, but we will assume it normal. It's here, huh? Yeah, we have but we don't have the speed only, okay? But we will have this calibration for it, but we will assume that the speed is normal, yeah. After, يلا. Limb leads أول حاجة الريت يلا. 1.5, 2, 3, 4, 5, huh? Less than 60. What is the normal? Yeah, yeah. This is 3 years. So, is it normal? We will go to the chart. We will look for the age. Yeah. 3. It should be from 73 to 137. Okay, so the patient is bradycardic. Okay? So the patient is bradycardic. Then after that, we will go for what? Is it normal sinus rhythm or not normal sinus rhythm? Normal, positive in 1 and 2, and AVF, negative in AVR. Then we will go for the P waves in lead 2. It's normal, it's not short, and it's not long. Then I will look for the Q in the 3. Do we find any Qs? We don't find any Qs. Then we will go to the chest leads, okay? We look for the T wave. It's negative in V1 or positive in V6. So this is normal for the patient age, yeah? Okay, so I'll shift to look for the R wave progression. Is it normal? Starting short, then it's growing bigger by time. Then, is the ST segment مسطرة? Then who will calculate the corrected QT here? Usually we calculate it either in lead 2 or in V5, sorry. Who will calculate here? Yalla, take and calculate. If I use this, I start to calculate from here till here. How many small squares do we have? حد يحسب يلا. حد يحسب يلا calculate. مين حسب؟ Who calculated? Oh, 511. Who agree? Because this is serious. Dr. Omar wants to send the patient for genetic testing, and he wants to have a full genetic evaluation of the family. He wants to have full relative screening by echocardiography. He's seeing some serious things. So he needs supporters. Anyone? Doctor? 490. Oh, this is also prolonged. We said, Dr. Ivan is saying 5. So you all agree that this patient have long collected QT. Okay, so this patient has prolonged QT. Bravo for all of you. This patient has prolonged QT, has normal sinus rhythm. He has prolonged QT. It's about 500, as you said. So this can be congenital or this can be drug-induced, and it can be in cases of hyperkalemia. It can be in cases of hypokalemia, in renal failure. So this is something serious, okay? Yeah, we'll go to the next patient. He is 18 years. What do we have? We have the calibration here. It's 2 squares, so it's fine. Calibration is not a problem. What do we have? What is the rate? Who will start to calculate the rate? Okay. Yeah, okay, it's 50 something. Yeah, after the rate, we have this patient on normal axis. Yeah, so the axis is abnormal. So as this patient is in normal sinus rhythm, he's positive in 1, positive in lead 2, negative in AVR, and positive in AVF. So this patient is in sinus rhythm. Okay. So what are we going to look for? P wave normal, as we said. Okay. Q waves in lead 3. No 3 waves. What do you think? Someone is saying something here. Bravo. Do we have a straight PR interval here? We have the B wave and the QRS complex is coming directly. So as if we don't have any PR interval. We have a very short PR interval, and usually this complex, it should not be coming like this. It should not be slurred. It should be straight, okay? So this is what we called, pre-excitation, Wolff-Parkinson-White syndrome. So this patient is in normal sinus rhythm. He has abnormal axis, as we said. He has very short VR interval. He has this delta wave, white QRS complex, and absent Q in V6, okay? Yeah, right axis. These are the typical criteria for diagnosis of Wolff-Parkinson-White syndrome, but usually we don't find them all in the cases. The most thing that we rely on is the short PR interval and the presence of the delta wave. Okay? Okay, yeah, next case. Bravo. Non-standard, it's only 1 square, okay? So we know that there is something abnormal here, and we are trying to correct it by putting half calibration. Okay, so if we go standard, what is the rate? Okay, axis is abnormal, it's negative in lead 1, okay? Yeah, so the axis is abnormal. It's negative in lead 1, and it's negative in AVF. So we'll have abnormal axis, okay? Okay, so is he in a normal sinus rhythm? What do you think about his PR interval? Normal? Okay, we will see it. Okay. What do you think about his B waves? Normal, huh? P waves, we will comment on the P waves in lead 2. Okay? P waves in lead 2. We'll find it normal. Okay, in lead 3, what we are going to look for? Q. What do you think about this Q? It's a little bit deep. Yeah, okay? Remember that we have half calibration. So here, we are having half calibration. So the Q here is around 2 big square. So if we adjusted the calibration, this Q will be very deep. Okay, so this patient have biventricular hypertrophy with prolonged QT also. So notice that there is half standard calibration, as you said. Why do we know that there is left ventricular hypertrophy? The R in V6 is more than the 96 centiles for age. You will know this also from this chart, okay? The R wave is very long in V1, okay? So this means this is abnormal. The R wave in V1 is is high, and the R wave, this V1 will speak to us about the right ventricle, and the V6 will speak to us about the left ventricle. So the R wave is high in both, okay? We know that if the R wave is high in the V1, this means right ventricular hypertrophy. If the R wave is high in left ventricular, in V6, this will mean left ventricular hypertrophy. We have here R wave that is higher than the normal in the two leads, V1 and V6. So this may mean my patient have biventricular hypertrophy, okay? And we can see here even by the eye. Look to the Q, very long Q space from here to here. If you found it, you'll find around 4 big square, okay? Usually it's around 2 squares or more. Here, it's very long, okay? The corrected QT here is 0.65. So this is very long. So this patient can have cardiomyopathy, severely dilated cardiomyopathy, patient of untreated VSD with in the old eras when we don't have a lot of surgeries for this patient, who will have patient with big VSDs left untreated, so they will have biventricular hypertrophy for the end. Yeah.
So, from the neurologist point of view, while working up cases of syncope or yeah. So we generally arrange for an ECG.
Yeah.
And for neurology person, not cardiology person. So what should be the cutoff duration? We used to take it 450 for them.
No, 470. So 470. Yeah. It also will depend about the age. You will find a specific number for age.
470 is very high.
No, because if you look for the Schwartz criteria for diagnosis of the prolonged congenital QT syndrome, they start to consider the patient prolonged. They give him half point if he's more than 480. Okay, and it's only one of the criteria, because they have to have the tachycardia for age, the abnormal T wave, abnormal T wave shape. We will look for the family history for the this. So 450, no. Okay, so, who want to volunteer? Milad, yalla Milad. Yalla, because you started to sleep. Calibration is okay? Okay. What about the rate? Okay, around 100. Axis? And AVF. One is negative, and AVF is also negative. So this axis, abnormal in both. Okay, yeah. Then we go to the P wave. Is it normal? P wave, it's little bit high. Okay. Then we look for the Q waves. What do you think? Deep. We are speaking about the ventricle who has a very thick heart. Sorry. Don't see. Yeah. This R and all this is S. Okay, all this is X. Sorry, something from here. Yeah. Okay. Yeah. Now we will go to the chest leads. What do you think? We'll start by T wave. Where's the T wave in V1? Negative in V1 and positive in V6. So this is normal for the age. What do you think about this QRS duration? Very wide QRS. Yeah? Sorry? Has PR of around 200 milliseconds. So we have first degree heart block. Okay? And then when we look for V1, you see this? Yeah, this is the R. Okay, then, yeah, as if the S is not there, and all this is R dash. Okay, so very, very small R, very tiny R, and the QRS is wide, and we have very high RS. So this patient has, yeah. Usually this a patient we will see after surgery, after cardiac surgery. Okay? Okay, so who will volunteer? Who will volunteer? This is easy one. We will always see it. Who will volunteer? We have normal calibration. We have normal calibration. What about the patient rate, heart rate? There is a regular, yeah, regular. Sometimes here we have very long R, then here we will have, like here, we'll have R's next to each other, then we'll have a big space like this. Okay, so this patient has something abnormal, okay? Does he have a normal PR? No. Okay. Yeah. So let's start by here. Here I have a normal beat, okay? This is B and this is normal PR. Then when I move here, I have a B, then the PR start to get a little bit longer, okay? Then what will happen here? The PR will start to get longer till when I have here a P and a dropped complex, okay? So when we start to have dropped complex, we are speaking about second degree heart block, okay? This is what we call Mopitz 1, when the PR start to be prolonged gradually till I drop 1, okay? So this is heart block. We know it from where. The most striking thing is from this part, when I have a B, but I don't have a QRS complex, because as we said, in the normal criteria to have normal sinus rhythm, I should have QRS complex after HP. So I have here Bs that doesn't have QRS complex to follow. So from here that I know that this patient has problem with head rhythm, okay? Huh? Yeah. So, no, it's not winky back. It's not winky back, no. No, it's Mopitz 1. Yeah, Mopitz 1. Yeah. It prolonged, then it's dropped. This is Mopitz 1, not winky back. Okay, now who will help me with this one? Okay. What do you think about this patient? What do you think about this patient T waves? Also negative. So this patient has a problem. This is the most apparent thing that we look, that this patient has a negative T in V6. So this patient cannot be a normal patient. Then this patient has ST segment it has changes. Like, yeah, when we look here, this is the PR, and here, okay. So this ST segment is abnormal. So this patient has something in his ventricles, yes? Yes. Yeah, so this patient has biventricular hypertrophy. This patient is in normal sinus rhythm. He has biventricular hypertrophy. Why? Because as we said, if we look to R wave in V1, this will give us idea about the right ventricle. R wave should not be this high in V1, okay? Then we will go to the R waves in V6. Where's the R waves in B6? Huh. Where's the R waves in B6? Huh. They are very tall. They are nearly hitting the other line. They are reaching the other line, the line above to them. Okay, so this is why we didn't notice them. Okay, so this patient has biventricular hypertrophy, and this patient has a short PR. Okay, this patient has also short PR. This patient has Pompe disease. Pompe disease will have cardiomyopathy. They will have giant complexes. Okay, they will have giant complexes, and they will have short PR. Okay. Yeah, so there is also, this is what, short PR, biventricular hypertrophy, short PR. This is very suggestive of Pompe. That is type 2 glycogen storage disease, and this ECG is characteristic. You will send the patient to the echo. You will have huge thickness in the wall, hypertrophy in the wall, and you will start the patient in replacement therapy, and he will have some improvement, not cure. Okay, yeah. So this patient is 2 months. Who's going to help? ليه؟ Supraventricular tachycardia, heart rate is 150. Wait, what about the axis? Huh. Huh. Yeah, it's positive in lead 1 and negative in F. So we are speaking about left axis, okay? Then P waves. Around between 2 to 3, so we consider it normal. Q waves. In lead 3, no Q waves. This is lead 3. No, this is R and this is S, not Q. So there is no Q waves. We will go to the chest leads. What do you think about the T waves? Negative in V1. Okay, let's look to the complex now. Yeah, RSR dash. Is it narrow complex or wide complex? When I found the RSR dash, I will look. Is it narrow complex or wide complex? Narrow complex. Is the R dash more than 10 square? Yeah, so I have right ventricular hypertrophy. Yeah. This patient has left axis deviation, as we said. This patient has normal sinus, has left axis deviation, as you said, and this patient has right ventricular hypertrophy. One of the few lesions in the cardiology that cause left axis deviation is the common AV canal and the tricuspid atresia. So from this ECG, we have left axis deviation, and we have left axis deviation and right ventricular hypertrophy. This is very suggestive of tricuspid atresia and common AV canal. So if my patient is cyanotic, mostly he will be tricuspid atresia. If he's non-cyanotic, he will have complete AV canal. Okay? Okay. يلا. What time are we? عايزين تروحوا؟ خلاص تعبتوا ولا نكمل؟ تعبتوا ولا نكمل؟ نكمل خلاص ربع ساعة. Okay. Yeah. Who want to help? Normal calibration. Normal rate. Normal rate. Normal axis. Normal axis. Normal sinus rhythm. Does this patient has normal sinus rhythm? Look with me to lead 2. He has positive, then positive, then negative, then negative. Okay, let's look to this. This is a complete one lead. Try to trace the P wave. It's positive, positive, positive. So what do you think? Who will say what? Wandering pacemaker. Yeah, because the P waves has different shape in P2. It's up, it's narrow, but the PR interval is regular, and this is usually normal, doesn't have any significance. Okay. Huh? What is the most striking thing when we look to this ECG? Bradycardia and what? Huh? Bradycardia and very big T wave. Usually we see this very big T waves. Huh? Yeah, in cases with the metabolic problems. Okay? So this patient also, what we have else? What do you see? Bravo, plus A. Let's look for the complete lead. Here I have a QRS complex without a B before, okay? Then I have a B wave here, okay? Then you see this, the T, and there is something on the T, something abnormal here. Then I have a B here, then without QRS complex. Then I have a B, then I have something here. Then I have a B, then I don't have QRS complex. So no any relation between, between the atria and the ventricle. So this is complete heart block, okay? With bradycardia, usually we have these patients with bradycardia. Thank you. Thank you. Thank you for sitting after this delayed time. شكرا. Remember that, يعني always.
الريجولار ريتم ازاي نحسب الهارت ريت؟ صح؟ مش احنا كنا كل ده كان ماشي
مش البوكس بيحسبوها بطريقه ثانيه. هي كانت موجوده في السلايد بس انا فوتها. هي شالت الكود. انا هقولها لك بس ايه. Can we go to the 10th slide? في طرق تانية لما يبقى عندك الطريقة اللي هي فوق دي. الطريقة اللي هي فوق دي. انت لو لقيته ان هو ابنورمال انت هتعرف ان هو ابنورمال وهتلاقي الماشين وهتلاقي الجهاز هو هيقول لك ان هو شكرا يعني thank you for staying up to now and anyone who didn't take cards والله على حسب نفس الكارت بتاع الناس مغيرين حاجه في الطباعه بس حاجه في الفورمات بس هو نفس الكلام خلاص ماشي لو عندك ثانك يو شكرا كتر خيركم كتر خيركم.
فالكابل اتولد
في الكيو 3 وعاده العيان الكيو 3 في الكيو في الليد 3 وبعدين عاده العيان بقى بيبقى انت جاي لك عشان هو عنده حاجه عاده جاي لك عشان هو بتحاول ان هو يطلع عنده كارديو جاي لي في الاكس راي انت
يعني ساعتها ال دي اتش فيرسس الكابل ولا؟
لا ما انت عشان لازم تلاقي بقيه الحاجات الثانيه بتاعت ال دي اتش لازم تلاقي الحاجات الثانيه
يعني لو لقينا حاجه واحده بس معناها
يعني مش هنقول هنشك فيه بقى نعمل له ايكو يعني احنا عمرنا ما نشخصه بالايكو بس
جميل الله يكرمك.
لازم نلاقي حاجات مع بعض.
ما فيش حالات بروجادا في الاطفال؟ وين تو سسبكت؟
لما تلاقي اول حاجه فاميلي هيستوري انك عندك جيناتيك وسادن ديث والحاجات ديت وكده وبعدين بتلاقي اللي هو النورمال QRS كومبلكس مش معايا البرزنتيشن